Morning, everybody. So today what I'll be covering is basically an overview of the postgraduate training in Jamaica and the Caribbean, as well as the urology services offered in Jamaica, a profile of our patients paying particular attention to stones, prostate cancer, and end-stage renal disease. So prior to 1970, all urology done in Jamaica was done by general surgeons. In 1970, Professor Ludlow Lawson Douglas, who was trained in Ottawa, was appointed chief consultant urologist at the Kingston Public Hospital. In 1973, he was appointed consultant urologist at University Hospital of the West Indies. Between 1970 and 1994, all urologists that worked in Jamaica trained in the UK and in Canada. In 1994, the Doctor of Medicine, which was our postgraduate program, was established at University Hospital of the West Indies. The first graduate was William Aiken in 1998, and since then, 13 persons have graduated from the program. Now, medical school in Jamaica is 5 years straight out of high school, and this is followed by 1 year as an intern, rotating through pediatrics, general surgery, internal medicine, and obstetrics and gynecology. This is followed by 1 year as a senior house officer, at the end of which you can choose to enter the urology program or any other postgraduate program if you choose to. The postgraduate program starts with 2 years rotating through the surgical specialties, and then DM1. DM1 is this huge exam which covers pathology, principles of surgery, anatomy, and physiology. If you pass, great, you move on. If you don't, then you need to change your career path, essentially. This is followed by 5 years in urology, the penultimate year being spent abroad. We have worked with a couple of international or national urologists. Professor Al Burnett from Johns Hopkins has been instrumental in us starting the AUA in-service exams. This started last year. We also work with Professor Chris Eden from the UK. He has been a proctor for laparoscopic radical prostatectomies at Cornwall Regional Hospital. So, Jamaica is essentially a dot in the Caribbean Sea. We have an area of about 10,900 square kilometers, or 4,200 square miles. We have a population of about 2.7 million, 600,000 of which is concentrated within Kingston and St. Andrew, which is our capital city, which is about here. There are 20 practicing urologists in Jamaica. Most of them are concentrated in Kingston and St. Andrew, and we have 4 in Montego Bay, which is on the western end of the island, and is essentially the tourist capital of Jamaica. 4 of the 16 public hospitals in Jamaica offer urological services. Kingston Public Hospital and University Hospital of the West Indies in Kingston, Cornwall Regional Hospital in Montego Bay, and Mandeville Regional Hospital, which is in central Jamaica. Healthcare is a 2-tiered system, both public and private. The services offered. KPH, the clinics average about 200 persons per week, and we have about 3 clinics per week. We average about 4 to 5 cases per day in the operating theater, and we have 5 operating days. At University Hospital of the West Indies, there are 3 clinics per week, averaging about 100 to 150 patients, and 2 operating days, averaging about 3 cases per day. Cornwall Regional Hospital, the numbers are similar to University Hospital of the West Indies. KPH is the largest urology unit in Jamaica. Every couple of years, we do an audit in Jamaica, and some of the figures I'll be presenting are audits from between 2010 and 2014. As you can see, this slide represents 2012-2013 new patient referrals, and the majority of our patients presented to us because of BPH and low urinary tract symptoms, retention, strictures, stones, elevated PSAs. In 2013, 33% of the patients that were seen for new referrals presented because of lower urinary tract obstruction. 27% presented because of stones, and 14% presented because of prostate cancer. The main operating theater, we have both a main and a minor operating theater. The main operating theater covers the major cases done. In 2013, 69% of the cases that were done in the main OT were done as an elective basis, and about 31% were done as emergencies. So this slide shows the cases done in the main OR between 2012 and 2013. As you can see, we do a lot of open stone surgeries, TURPs, we do a lot of OIUs, TURBTs. For some reason in 2013, we had a record number of penile fractures. Not quite sure why, but yeah, we do have a lot of penile fractures.
More penile fractures than non-prostatectomy.
Yep, it has happened. There are 3 fellowship-trained endourologists in Jamaica, 2 operate in Kingston and 1 operate in Cornwall Regional Hospital. Now, is there epidemiological data for renal stone surgery in Jamaica? The answer is no. Do we see a large number of stone surgeries, stone patients in Jamaica? The answer is yes. What data do we have? In 2010, 16% of the 1,898 new patients seen presented to us because of renal stones. In 2013, 15% presented because of renal stones, and in 2014, 20% presented because of renal stones. For the years assessed, new patients with renal stones equaled BPH, which was about 858 each. In terms of elective surgeries, stone surgeries in 2010 accounted for about 20% of our elective surgeries. In 2013, 27%, and in 2014, 15%. The increase seen in 2013 happened because we had more operating time, as well as we had a working C-arm. In 2013 or 2014, the C-arm broke, so our case number decreased. The reality is that at KPH, we have no ESRD, we have no lasers, we have no flexible ureteroscopies, we have limited disposables. In fact, patients have to pay for their disposables, and we have old equipment. This picture on the right is the C-arm that we obtained in 2013, and which subsequently broke. Is a refurbished C-arm that we got. ESRD is available at UWI. We have a Dornier machine. Laser is available at 1 private hospital. We have newer C-arms at UWI and at KPH, but like we said, at UWI there are only 2 operating days. In terms of open stone surgeries, we still do a variety of open stone surgeries, anatrophic nephroliths, ureteral lithotomies, cystolithotomies, and between 2009 and 2011, our stone-free rates were 58.3%. In terms of ureteroscopy at KPH, all is done with a semi-rigid scope and pneumatic lithotripsy. These are actually privately owned. 58 elective ureteroscopic procedures were done between 2012 and 2014. We don't have details of the stone burden for those patients. Our stone-free rate was about 83%. The Clinical Research Office of Urological Society, in their study in 2014, demonstrated stone-free rates of about 77 to 94%. This was for 32 countries, 9,864 ureteroscopies. So our numbers are somewhat in the middle. For percutaneous nephrolithotomies at KPH, we did 41 procedures between 2011 and 2014. We have info available for 39 cases. They're done both prone and supine. They were all done by 1 endourologist, and he obtained his own access. 12 staghorn stones were done, 3 lower pole stones less than 2 centimeters. All others were greater than 2 centimeters or multiple stones. Our stone-free rate was 72%. The Crow's PCNL Global Study, their stone-free rate was 75.7%. In terms of end-stage renal disease in Jamaica, about 500 new end-stage renal disease patients are seen per year. The last transplant that was done at KPH was done in 2011. For the vast majority of patients, hemodialysis is the treatment for end-stage renal disease. Majority of our patients are in Kingston and St. Andrew, and that might be because of the two largest referring hospitals, UA and KPH, are in Kingston. Majority of the patients or causes of chronic kidney disease are hypertension, diabetes mellitus, SLE, and chronic glomerulonephritis. As I said before, hemodialysis accounts for the majority of renal replacement therapy done in Jamaica. Dialysis carries a significant economic burden in Jamaica. Bear in mind that Jamaica is classified as having a lower middle income economy. Majority of our population don't earn enough money to be able to cover 3 dialysis sessions per week, which is what is required. So majority of patients end up doing only 2 sessions per week. Our exchange rate is about 90 to 1 at a cost of $6,500 session per week, per $6,500 per session. It adds up, and a lot of people can't afford to do dialysis on a weekly basis. Dialysis carries with it significant morbidity. Majority of the admissions are secondary to dialysis catheter-related reasons or infections. A study done by some of our nephrologists in Jamaica, they demonstrated that a lot of the patients complained of a reduction in their physical role in the family, their emotional role, as well as a reduction in their general health, and of course their earning potential whilst on dialysis rather. In terms of transplant history, the first transplant that was done in Jamaica was done in 1970, and this was done by Dr. Lawson Douglas. So he did about 3 to 5 per year until 1993, with a total of about 100 performed, a success rate of about 75%. But in 1993, it essentially stopped. I'm not quite sure why it stopped, but we've done very few transplants since then. The current status: 4 transplants were performed over the last year. All were done at Cornwall Regional Hospital. All were private patients. Living donor laparoscopic nephrectomy was done. All the patients are doing well. And whilst this is good, there are no transplants to be done in Kingston, at least none for the last 2 to 3 years. Our challenges to transplantation: a limited donor pool, as well as infrastructural challenges. There's the lack of availability of ICU bed space. There's the inability to fund a complete on-call nationwide transplant team, the cost of HLA compatibility testing, cost of surgery, and the cost of immunosuppressive drugs. There's also, of course, the lack of operating time, the fact that we average 3 cases per list. This is at UA. And we have a waiting list in excess of 350 patients, adding about 9 patients per week to that list. For prostate cancer, the major ethnic group in Jamaica is Afro-Caribbean. This accounts for 91% of our population. Prostate cancer accounts for almost 1/3 of all our cancers. So we are inherently a high-risk group. Local data between 2003 and 2007 demonstrating that prostate cancer was the highest cancer seen, or the largest, accounted for the largest number of cancers seen between 2003 and 2007. In 1984, Frank Glover, I think he was at Johns Hopkins at the time, did a study, the epidemiology of prostate cancer in Jamaica, and demonstrated an age standardized rate of 304 per 100,000, and concluded that Jamaican men in Kingston had a high incidence of prostate cancer, even higher than Black Americans for that period. Our current figures are less than what Glover demonstrated. We now demonstrate an age standardized incidence of 78.1 per 100,000, much less than Glover's report, but still the most common cancer in Jamaica and Jamaican men. an age standardized mortality of 53.9 per 100,000. The figures quoted by Glover have never been repeated in Jamaica. And yeah, this just demonstrates what our current figures are. In terms of local data, like I said, our mortality is 53.9%. This was in 1999, sorry. And the USA, the mortality data was about 22.3 per 100,000, UK 23.1 per 100,000. And Canada apparently was similar to the USA at that time. And this is based on Canadian Cancer Registry. PSA testing has been available in Jamaica since 1989. There are no formal national screening policies available. The most organized screening is done by the Jamaica Cancer Society. It is a volunteer society, and screening is done by local urologists. There are barriers to screening. Fear of the DRE. Jamaican men just don't like have a digital rectal examination done. There's fear of the male gender doing the examination. In fact, our most popular urologist in Jamaica is a female urologist, Dr. Belinda Morrison. Fear of the diagnosis of a medical disease, socioeconomic reasons. Although the cost of the PSA is low, persons still have to pay for it, and it comes at a cost for persons who can't afford it, as well as fear of treatment-related adverse side effects. Options for treatment. Active surveillance is available to us. It's practiced, but rarely. We have a high-risk population where we are wary of extrapolation of data from the Caucasian population. And frankly, our men are not likely to adhere to the follow-up protocol. Radical prostatectomies are done very commonly. Most are done open. One urologist does them laparoscopically, and this is at Cornwall Regional Hospital. Morrison et al. In 2011 reported on outcomes of radical prostatectomies done at University Hospital of the West Indies and demonstrated a biochemical survival-free rate of about 78.4%. Now, due to deficiencies in chart reporting, we were unable to demonstrate our functional outcomes in terms of erectile function as well as incontinence. However, major complications were rare, and there was no perioperative mortality. Chad Rich, who is of Jamaican parentage, when he was at Columbia University, did a study on the pathological outcome and biochemical recurrence-free survival after radical prostatectomy in African American, Afro-Caribbean, in particular Jamaican men, and Caucasian men. And he demonstrated that Jamaican men presented at a slightly older age at 6:1 versus 58. We had a higher PSA at 8.8 versus 6.15. More than 44% of our men presented with a Gleason score of 7 or greater versus 8 and 0 in the African American and Caucasian American population. Jamaican and African American men had worse pathological outcomes after radical prostatectomies. Our 5-year biochemical free survival was similar for Jamaican and African American men and less than for Caucasian American men. Brachytherapy is available. It's offered in the private system. EBRT is also available. 2 public hospitals, KPH and Cornwall Regional Hospital. We use Cobalt, old machines. It's used for other cancers all across the island, which makes for a very long wait list. Privately, the Varian Linear Accelerator is available, and this comes at a cost of about 1 million Jamaican dollars per session. ADT is available, both surgical and chemical. The National Health Fund, which is a government-run agency, now subsidizes our drug treatment and enables greater access to these medications. Goserelin is available, buprolide, bicalutamide, and flutamide, and more recently, abiraterone has been added to our armamentarium for treatment. That is it.